here we start, guys, the first section being the deformities, and I do believe by this time when you are watching these videos, your all the content is done and you want to revise orthopedics after your first reading or the second reading or the complete reading with the MCQs and everything else of orthopedics. Okay, so starting with the deformities, you know how we define something as varus or valgus. When the part of the limb distal to the joint, it goes medially, we are going to call it varus. For example, here the forearm is deviated medially, so what are we going to call it? We are going to call it varus, isn't it? And had the elbow, this forearm would have been going laterally, for example here, we would have called it valgus. So when the part of the limb distal to the joint goes medially, it is varus, and when it goes laterally, it is valgus. So here in this scenario, the first word to be used is for the joint, and the first word we are going to use, it is cubitus, right? Cubitus is the word we use for elbow. And the deformity that you see, the part of the limb distal to the joint, it goes medially, is what you call as varus. So cubitus varus deformity. Where do we see the cubitus varus deformity? It is seen in malunited fractures of the supracondylar humerus injuries. When they are malunited, right? And now do remember, it is about the malunion. And why the supracondyle is going to malunion? Because they are metaphyseal areas. They are soft cancellous areas of the bone. They have the high potential to unite because of high vascularity, right? And when you are treating, when you are reducing the supracondylar fractures, whenever there is an injury, what angle you should draw after your reduction, after your fixation, that tells you that yes, the patient is having a proper angle and they will not have a deformity later on. That is known as the Bowman's angle, right? That is known as the Bowman's angle. How much is the Bowman's angle, normal angle? It is between 64 to 81 degrees. And when you are drawing it, if your angle on your X-ray comes out to be more than 81, it is suggestive that the patient will have varus deformity for sure, right? The patient will have a varus deformity for sure. So it is cubitus varus deformity this child is having. This one, this fellow, what is having, the first word is again for the joint. Which joint? The elbow joint. And here the part of the limb distal to the joint, that is forearm, is going laterally. So it is valgus, right? Where do we see cubitus valgus? Cubitus valgus, it is related to the non-union of the fracture lateral condyle or epicondyle of the humerus. When there is a non-union of these fractures, and why these fractures go into non-union, or what's the other name for these fractures? We also call them the fractures of necessity. What does it mean? I do believe you remember that fracture of necessity are those injuries which require surgery for sure. If you're trying to conserve it, there are high chances it will not unite and it goes into non-union, leading to progressive valgus, right? Leading to progressive valgus. So this is the cubitus valgus deformity, which is there due to the non-union of fracture lateral epicondyle of humerus or the condyle of humerus because of attachment of the common extensors origin, which does not allow the bone to stay in place, the fragment to stay in place. So therefore, this one is a non-union, supracondylar has been your malunion. Okay. Then these deformities, here the involved joint is the knee area, right? Here the involved joint is the knee area. So the word that we use for the knee, it is genu. So part of the limb distal to the joint is going where? Medially. The legs are going medially. So what am I supposed to call it? Genu varus. And genu varus can have the causes as rickets as well as when somebody is having osteoarthritis. When somebody is having osteoarthritis, which compartment osteoarthritis? This medial side collapse, the medial compartment OA. So it has to be the medial compartment OA. Both of them, they can very well cause the genu varus deformity, right? Rickets, we know that at birth every child is having a genu varus, and this genu varus continues till the age of 1 to 2 years, when it becomes a neutral angle, and after 2 years of age it starts gradually going into valgus, right? So genu varum is a normal physiological, you can say, the alignment of the limb when the child is born, a newborn baby, right? This one you will call it as genu valgus. This one you are going to call as the genu valgus because the part of the limb distal to the joint is going laterally. And here again the causes can be very well rickets, or the causes can be very well osteoarthritis. But here what changes? Here the age in osteoarthritis will change because in rickets, you know, at birth there is varum, but after the age of 2 it starts going into valgum. And this valgum, it is maximum in a child at what age? Maximum valgum is seen by the age of 3.5 to 4 years. Maximum valgus is at the age of 3.5 to 4 years, which gradually declines and becomes a normal valgus by what age? It becomes a normal valgus by what age? By 7.5 to 8 years. And how much is the angle we all have as a part of mature skeleton? It is 6 to 8 degrees of valgus. It is 6 to 8 degrees of valgus. That's what we have right now, right? And again, talking about the osteoarthritis, when there is an arthritis of the lateral compartment, so we get a patient having a lateral compartment leads to a valgus deformity. So lateral compartment osteoarthritis. It is a lateral compartment osteoarthritis, a xenovalgus deformity, the xenovalgus deformity. Okay. Then when you talk about the great toe, these are the deformities where the great toe is deviated laterally like this. So great toe, what do we call that? Hallux. It is hallux. And when the lateral toe is, deviated laterally, what do we call it? Hallux valgus. Right? Hallux valgus. What does that mean? The lateral deviation of the great toe. The lateral deviation of the great toe. That's hallux valgus. The lateral deviation of the great toe. Okay. When the great toe will be moving, basically the hallux word is for this joint area. So first word of any deformity will be telling you which joint is involved. And this one is the one where the great toe is going medially. So what do we call this now? This is known as the hallux varus deformity. This is known as the hallux varus deformity, right? That's hallux varus deformity. So hallux valgus, hallux varus. Now the last point which I want to take up here is, what about the hip joint? What about the hip joint? So you have to remember, guys, in the hip joint, the angles, the deformities are made by what two lines? One line which is along the shaft of the femur, and second line which is along the neck of the femur, isn't it? And that's what you call as what? That's what you call as what? The neck shaft angle. That's what you call as the neck shaft angle. And how much is the normal neck shaft angle? We know normal neck shaft angle. How much is the normal neck shaft angle in the matured skeleton? It has to be like 120 degrees approximately. We say like it is 120 to 135 degrees for all of us. So broadly it is 125. Whenever the neck shaft angle will decrease, we are going to call it what? The coxa vara. We are going to call what? Coxa vara. And what are the common causes that you know for coxa vara when the neck shaft angle decreases? Most commonest will be your fracture neck of the femur. Then in the tumors, it is the Shepherd Crook deformity. Do you remember? Where do we see this Shepherd Crook deformity? It was in the tumor fibrous dysplasia. Remember that? The fibrous dysplasia. And third, obviously, when the bones become soft, for example, in the cases of rickets. Right? Valgus, when I want to talk about the coxa valgus, the hip deformity, where do we see the coxa valgus? The coxa valgus will be seen only in one special condition, and that is a Gardner's type 1 injury. Do you remember Gardner's type 1? Gardner was a classification for fracture neck femur, and in that the type 1 injury was the one where the head was going into valgus and impaction. So that is your coxa valga. That is your coxa valga and coxa vara. So for hip, do remember the Shepherd Crook deformity, the rickets, right? Softening. So Shepherd Crook can be very well a image based question. X-ray they are giving you, and they want you to identify the kind of tumor it is showing you. So that can be a upper end of the stick bent like this. The stick which is carried by the shepherds to hold on or control the herd of the sheep or the goats, which I'm going to show you when we talk about the tumors as well, right? So this is about the deformity part, guys. Deformity can be a straightforward image-based question. It can be like a theoretical question where they ask you a topic like supracondylar, lateral condyle, and they give you clinical implication that after some time the patient is coming with so and so kind of deformity. What can be the most probable reason for that? Right? So that is your first section of deformities. I hope your revision is going very, very quickly. So with the deformities, when we talk about deformities, one thing you have to keep in your mind that whenever we have the deformity, whenever we have a patient who has got deformity, and this deformity is like flexible deformity. When this deformity is a flexible deformity, how do we treat it? Any deformity in a child or adult, flexible deformities are being treated by tractions, right? They are being treated by tractions. They are being supported by splints. And whenever there is a fixed deformity, then how do you are going to treat it? It has to be done by surgical method, that surgery. And usual surgery done for any of the fixed deformity is osteotomy of the bone, cutting of the bone, right? Cutting of the bone and aligning it. So traction splints are used for any of the flexible deformities. That's your points. These are the important points from the section of deformities. Let's move on to the next one.